Good morning. It's always great to be here and to have the opportunity to talk about MPNs and kind of drill down into some of the basics so that I think hopefully a lot of you will walk out of here with more information and maybe and hopefully that lessens some of the anxiety regarding the diagnosis. So what I'm going to do is kind of just walk you through the basics of diagnostic tests that we do and really kind of a brief overview of the diagnoses of ET, PV, and MF. And it's kind of going to be a high-level thing, and if there's questions, just shout them out to me. So let's start with the basics, which is that we like to put things into boxes, right? That's how we try to categorize things. And so we have PV, and we have ET, and we have MF. The reality is they don't always care what we think the disease is. And there's a lot of overlap between them, and that's an important thing to recognize, and I'll come back to that at the end of the talk. But, you know, PV, there are defined criteria for PV, there's defined criteria for ET, and there's defined criteria for myelofibrosis, and MF can occur after ET or PV, it can occur as the initial diagnosis, and then there's a newer entity called pre-fibrotic MF, which kind of shares a lot of characteristics with ET. That's one thing. The other thing, though, is that the diseases can change. So sometimes people will start out with ET and it'll actually turn into PV for reasons that I don't think we entirely understand. And that, as I said, all of these diseases can turn into MF. And MF itself, or PV or ET directly, can turn into full-blown leukemia. So that's how we think about things. But again, remember, one of the principles here is that these are not always clean, nice boxes like we put them on the diagram. It just doesn't work that way in real life. And it's, you know, many of you may end up at some point or even at the beginning with a diagnosis that doesn't fit into these categories. And there's things called MDS MPN overlap syndromes where it looks like MPN, but there's features of something called myelodysplastic syndrome. Sometimes people end up with what's called an MPN unclassifiable. It's an MPN, but we can't put it into one of those boxes. There's something called MDS with fibrosis, where people actually have bone marrow fibrosis and an enlarged spleen, but they don't have an MPN. It's an MDS. And then there's something called chronic myelomonocytic leukemia, in which 5% of patients have a JAK2 mutation. And so the point here is that the diagnosis is not always straightforward, and it's worth talking and making sure you understand what precisely your physician has diagnosed you with. And it is possible that there's ambiguity in the diagnosis. It doesn't mean somebody is wrong about the diagnosis, it just means sometimes we can't entirely figure it out. So let's talk a little bit more about how we make diagnoses and how we do tests. So there's a number of tests that go on, and many of you are familiar with these. One is the bone marrow exam. So the bone marrow exam, it really involves two things. It's to take the liquid portion out that's called the aspirate. So the bone in the interior is kind of soft and spongy, and that's where all the blood is made. And so we do take the liquid out, which in patients with MF doesn't always work. And that tells us what kind of cells are in the bone marrow. And then there's the biopsy itself, and that tells us about the architecture of the bone, and it allows us to stain for different things like fibrosis and really understand what's in there, okay? And then there's a number of associated tests that we do from the bone marrow, and those include chromosomal analysis, and that's sometimes called cytogenetics, or something called FISH. These are both ways to tell us if chromosomes are abnormal or not. There's mutational analysis, or sometimes called NGS, which stands for next generation sequencing, or also called molecular genetics. There's the bone marrow cellularity, bone marrow fibrosis, and the morphology. Now, the point here is not that I want you to all become pathologists, but you get your reports, and these are sort of the basic terminologies that it would be good to be familiar with, and talk to your physicians about this, right? Ask them to explain these things to you. But I'm going to take a deeper dive in because I've just thrown a lot of terminology at you, okay? So again, this is what we learn from the bone marrow. Some of these things you can learn from the blood. Usually the molecular genetics, sometimes the chromosomes you can get from the blood itself, but oftentimes we get this from the bone marrow biopsy. So let's dive in a little bit deeper and talk about what's a karyotype, right? So chromosomes, we assess by what's called karyotype, and if anyone has ever had kids, they talk about karyotype and they do an analysis of this. But you have 23 pairs of chromosomes, and you get one from your mother, one from your father. And what we look for when we do karyotype analysis from the bone marrow is there something structurally wrong with the chromosomes? So here, there we go, perfect. So this is a normal karyotype. And this shows all of the basic pairs of chromosomes and how they should look normally. I had a job doing this when I was in college. They let me go because I didn't do a good job. It's complicated. Now, here's an example of where there's an abnormality. So you see here in chromosome 7, if you look at the pairs, they should look the same, but here this individual is missing a piece of chromosome 7. So we call this, in a report, it would say deletion chromosome 7. Part of chromosome 7 is missing, which is not usually a good thing. But this is one of the things we try to figure out when we do the bone marrow. And so when you have your bone marrow reports, you'll often see the karyotype analysis listed there. But one of the things you have to do is ask your doctor, what does it mean? What do I have? And what does it mean? Okay, but this is just kind of, again, giving you the terminology. So let's walk down the list here. So we've talked about chromosomes. Let's talk about mutations. So what are mutations? So the basic principle, and I know I'm trying to be as broad as possible because I know for some this is too basic, for some this is not too basic. But the basic idea in biology is that you all have DNA, and DNA gets transcribed into something that's called RNA, and the RNA is then made into proteins, and the proteins are the things that carry out the functions in the cell, and being simplistic on purpose here. But mutations refer to changes in the DNA. So the DNA is encoded by 4 letters, G, C, A, and T, and from that you get the incredible genetic variety that we see in humans. A genetic alteration can be a number of different things. It can mean that, for example, if the normal code should be GCAT, that this A became a C, and that is what we call a polymorphism. We call it a mutation if we think it has a negative consequence, but that is an example of a mutation. Another example is that, let's say this is the genetic code and it gets cut off. This is something we would call a deletion. And so sometimes we see that in patients with MPNs where this is one of the mutations or alterations that we see. And then another example is here. If this is, for example, is the genetic code, there is an insertion of genetic material that doesn't belong there, and that disrupts the code. And so that's called an insertion, as an example. So there's a lot of different ways that the DNA can get corrupted, but this is what we're looking for when we do what's called NGS or mutation testing, okay? So far so good? Okay, so let's talk about bone marrows. So this is a high-powered view of a bone marrow biopsy. So when we do the bone marrow biopsy, what we actually end up with is like the people seem to be of the right age that I can still talk about pencils because I don't think anybody under 20 knows what a pencil is anymore. But if you think about the center of a pencil, the lead, I know they're not lead anymore, this is what it looks like. And so this is, if you put it on a glass slide and looked at it under the microscope on a low power, it would look like this. It just looks like a tube of cells. And we can tell a lot about the bone marrow and how that relates to the potential of the diagnosis. So this is kind of, again, the high-powered view. This is what a normal bone marrow looks like. Now, what we look at in the bone marrow is what do the cells look like, how close are they together, how many of them are there, and what is the cellularity. So what the cellularity is, which helps us kind of determine what the MPN is, it's the ratio of fat. So all of these white globules are fat globules, and the rest of these are cells. And so it's the ratio of fat to cells. And so what somebody's bone marrow cellularity should be is 100 minus their age. So if you're 30, it should be 70. If you're 70, it should be 30. In most MPNs, it is altered, not in essential thrombocythemia, which is an important point, but the relative cellularity gets altered. And so this is an example of somebody who has way too many cells. This is called a hypercellular bone marrow. This is kind of often what we see in myelofibrosis, where you see very few fat globules, maybe just one or two here, but the rest of it is all cells, and this is inappropriate. And so that would be a concerning feature that we would see in the bone marrow. And this is somebody who has a hypocellular bone marrow, where there's very few cells and there's lots of fat, okay? This is very uncommon with MPNs, and sometimes in late-stage myelofibrosis you see this, but not common. So again, this is just talking about what do we see when we look at the bone marrow. Now, what does it look like in different MPNs, just as an example? In patients with essential thrombocythemia, as I said, they have a normal cellularity for their age. They have these cells that are called megakaryocytes that I'm pointing to here, and those are the cells that make platelets. But in patients with ET, they tend to come close together, whereas they should be far apart in the bone marrow, and they look abnormal. In patients with polycythemia, you can see that it is a very hypercellular bone marrow. And this is why it's important that people have bone marrow exams at the time of diagnosis, because there can be, remember, going back to the first slide, there can be ambiguity between what the diseases look like from the blood, but if you do a bone marrow, sometimes it will give you the exact answer, that there is a difference and this looks like PV rather than ET. And then there is myelofibrosis. And in myelofibrosis, what you can hopefully appreciate is that there's distortion here, right? It's not kind of the smooth picture that you see in panel A and B, but there's actually kind of a distortion in the bone marrow, and that comes from the fibrosis, which actually can cause the bone marrow to curve and distort. And we see that these are the megakaryocyte cells I was talking about a moment ago. They look very bizarre. They don't look normal at all if you compare them to panel A. So those are some of the hallmarks that we see in patients with myelofibrosis. And of course, myelofibrosis involves fibrosis. So this is one of the things we get from the bone marrow biopsy Ps. If you look over here, this is a patient who has no bone marrow fibrosis, and this is the same patient with bone marrow fibrosis. And these are these lines, the dark lines here. Now, not every disease that has fibrosis is myelofibrosis. Patients with PV can have fibrosis, and I mentioned there's other diseases in the same family that also have fibrosis. Things like MDS sometimes can have fibrosis. So it's one of the things we check for, but it doesn't mean somebody has myelofibrosis. So then let's talk now a little bit more about the genetics and the mutations. What are the mutations that we look for to make a diagnosis? Well, everything in MPNs is really based on activation of what we call the JAK-STAT pathway. And this is a cartoon that shows you the outside of a cell and the machinery inside the cell. And JAK proteins live inside the cell, and they take signals from outside the cell, and they become mutated in essentially 99% of patients with PV and about half of patients with ET and MF. There is something called calreticulin, which was only discovered in 2013, and that's mutated in 30 to 40% of patients with ET and MF. It's not really seen in PV. And then there is a mutation in something called MPL, and that occurs about 10% of patients with ET and MF. Now, they all complex together, meaning that if you look out here, MPL is something that transduces signals from outside the cell into the cell, and it complexes the JAK2. So it kind of makes sense that if you have a mutation in one or the other, it can give you the same sort of disease. Calreticulin is a little bit more complicated, but calreticulin binds to MPL, as it turns out. So we don't entirely understand how it works right now, but again, it's all in the same pathway. It makes sense that if you corrupt one or another part of the pathway, you end up with sometimes a very similar disease. Now, one thing that makes diagnosis complicated is that despite all of this, there's still about 10 to 15% of patients where we can't identify a mutation. Their bone marrow looks like MF or ET, and we do all of the testing, we do the NGS, and we come up with nothing, right? Those patients, in many cases, really do have an MPN, but we just haven't figured out exactly what the mutation that they have is. Now, there's subtleties in how genetics are done. In many places, when they do genetics, they look for an exact mutation, whereas in other places, they look more broadly across the gene and say, we're not just going to look for one mutation, we're going to look for any mutation. And sometimes that gives us the answer. But that is something to talk about your physician if you end up in a situation where they can't find a mutation. Now, as one goes through the diseases, there are more mutations. So PV patients tend to have some more mutations than ET, and MF patients tend to have more mutations than any other of the MPNs. Some patients have 5 mutations or 3 or 4 mutations. And looking at how often these occur, it's actually not so common. Most patients have, JAK2 or a calreticulin mutation, but then all of these other mutations that can occur in less than 3% of patients, right? So we're talking about not common, but they are important, as I'll talk about in a minute. So let's talk a little bit about ET and PV. First, so ET, you have to have an elevated platelet count to be diagnosed with ET, and patients can have a lot of different symptoms. Anne was talking about this at the beginning. There's a spectrum of symptoms, right? Patients can often complain of headaches, tingling in their fingers or legs. Not as commonly, but sometimes patients will have night sweats and fatigue or itching, but again, that's not as common in ET. Rarely people will have an enlarged spleen. So again, there's common, but uncommon things happen. We worry about clotting, cardiovascular complications. We also worry about bleeding. And as we talked about at the beginning, the disease can progress into leukemia or myelofibrosis. But at the end of the day, clotting is the biggest risk if you look at the incidence of 17% at 15 years. So that's really what we worry about when we think about ET, when we meet somebody with ET. Now, one thing to be cautious of, again, if you've been diagnosed with ET is it actually ET? The only way to know that is to do bone marrow. And there is this entity that I mentioned a moment ago called prefibrotic myelofibrosis, which if you think about ET and MF kind of on a spectrum, it's sort of in between. And this was really only became a conversation around 2008. But patients, what was noted was patients looked like they had ET, but they were progressing at a higher rate than was expected. And when people did careful examination of the bone marrow there was a group in Italy that did this, they found that the bone marrows are actually a little bit different. And so patients with ET, as I mentioned, have a normocellular bone marrow, but patients with prefibrotic MF who will present with a high platelet count may actually have a hypercellular marrow, which they shouldn't have if they have ET. Sometimes they have a slight elevation in their white count, and sometimes other markers are a little bit off. So again, this is the importance of doing the bone marrow because it can tell you a subtle difference between ET and prefibrotic MF. There isn't anything at the moment we would do differently between these two diseases, so somebody could argue, why are you doing the test if you're not going to be able to tell the difference, or you're not going to do anything different for somebody? But the thing is, they have somewhat of a different prognosis, and you have to think about them differently. And this is just an example of a bone marrow. Again, patients can look exactly the same from their blood work. They can have no symptoms, just a high platelet count, but their bone marrows look very, very different, and that's why it's important to do the bone marrow. So how do we think about, I'm not going to get too much into the treatment. I know others are going to talk about this, but one of the points here, again, is that we think about blood clotting, and so we put people into different risk groups, and that kind of tells us how we treat them. But that used to just be based on somebody's age. Now it is based on the genetics. And so, as I mentioned, patients can have a JAK mutation, a calreticulin mutation, or a MPN mutation. But it turns out the patients with the calreticulin mutations have the lowest risk of having a clot with ET. And so there is a category called very low risk of clotting, low risk, intermediate risk, and high risk. So people with the JAK mutations really are only going to be in the low risk or the high risk group. But patients with a calreticulin mutation can be in any of these groups, and it does change how we treat patients. So this is part of why it's important to have a good genetic analysis as part of your workup. It can change how you're treated. Does it matter in terms of the disease progressing? It's early. We don't know enough about this yet. There's some early data to suggest that the genetics might divide patients in terms of who's more likely to progress into leukemia or to progress into myelofibrosis if they have certain mutations. This has to be validated, and so I'm not going to get too far into this just to suggest that it may be important for prognosis, but there's more work that needs to be done here. So let's talk a little bit about PV. To have PV, people generally have to have an elevated hematocrit or red blood cell count. Now, there are cases where patients present with high platelets and their hematocrit is normal. But one of the classic things that can happen, and again, one of the reasons why it's important that your doctor takes a good medical history and also does a bone marrow biopsy, is that iron deficiency can cause the hematocrit in a PV patient to come to normal, which is actually one of the ways we treat it. But you can see that in patients who, for example, have a bleeding disorder for some other reason, or women who are menstruating will have iron deficiency, particularly younger women, and they may present with a normal red blood or normal hematocrit but a high platelet count, and the temptation is to say, well, this looks like ET because they have high platelets and their hemoglobin's normal. But in fact, if you look more subtly and you look in the bone marrow, you will see that in some of those cases you're actually dealing with PV. So again, a good medical history and in many cases doing the bone marrow. In PV, we worry, again, as with ET, about cardiovascular complications, clotting, and bleeding. And so those are the major things that guide our treatment right now. The symptoms are different to some degree, and patients tend to be more symptomatic, but itching is one of the major things that we see. Sometimes shortness of breath. Fatigue is one of the most common symptoms, and spleens can get bigger in PV, more often than what we see in ET. We worry about, again, the progression of this to myelofibrosis and to leukemia, and that occurs more often than in patients with ET. 99% of patients have a JAK mutation. It's not uncommon that we get a referral for a patient who has been tested and they don't have a JAK mutation and they have a high red count, and there's a lot of different reasons that can be, but that always requires a thorough evaluation. Right now with PV, we really have an inadequate system for how we think about patients' risk of progression, and that could be, we put them into low risk and high risk, and that's it. And that doesn't really help anybody. It doesn't really tell an individual what is your risk of having a clot, right? We put people into large groups, and this is something that really needs focus, and a number of people are investigating how do we make this a better model. The same thing, as I mentioned with ET, is true with PV in terms of thinking about what's the risk of the disease actually progressing into MF or leukemia. And again, it's early days, and we have some sense of some of the things that might matter, and those things could include mutations. They can include an abnormal karyotype that we just talked about, the age, and the white count. And that may suggest that some patients are more likely to progress to leukemia or to myelofibrosis. But again, this needs validation. So let's finish with myelofibrosis. And so MF really is a spectrum. There are people who have MF who have abnormal blood counts but otherwise feel perfectly fine, and they may do fine for a decade or more. And then there are patients who come to see us and are terribly symptomatic, and people can have drenching sweats, weight loss, a big spleen that causes pressure in the abdomen. They can't eat well. They feel like they have the flu all the time. They have body aches. It can be a lot of different things. And what we worry about with MF is a number of things. It can cause worsening symptoms over time, and that can impact people's quality of life and what they can do in their life. I think that's an important thing to think about. It can cause the liver and the spleen to get quite big and become uncomfortable. Eventually, it can lead to the bone marrow burning out, and that leads to low blood counts. And ultimately, we worry about it progressing into leukemia. So our perspective with MF is a little bit different than with ET and PV. How do we think about, what's somebody's risk of progressing, right? One of the most common questions when we sit down with somebody who is newly diagnosed with MF is, what's going to happen to me, right? This is, of course, a very rational question. And we don't have a crystal ball. We can make a guesstimate, and we have more data here to tell us, to kind of stratify patients into different groups. And we can do that from just clinical factors, right? Based on their age, whether or not they have symptoms, if they have anemia, if they have a high white count, if they have early blood cells in their peripheral blood. And we can stratify people by what's called the IPSS. And if you look at the curves here, this is the survival of patients with MF who were put into these different groups. And you see the curves are different, right? So it does give some sense of who is at a higher risk of progression and who is not. And this has been more refined with other versions of this. We don't have to go too far into this, but it's really a lot of the same factors that go into this. But again, if you look at the curves, you can see that, if you look at 5 years, these patients who are in this high-risk group have a much lower chance of survival versus somebody who's in the low-risk group. So it gives a relative sense, and it doesn't predict anything. I think that's one of the major things you have to be careful of when you're asking your physicians about what's going to happen. None of these tools predict. They just give us a relative sense of what might happen. Now, the genetics matter here, and this has been better studied than in the other 2 diseases, and this is why I think, in my opinion, it's important to have an extensive mutational test, because we know that there are certain mutations, and I've put the names of some here, that are associated with the disease having a more aggressive course. Again, that doesn't tell you how to treat somebody, but what it does tell you is that somebody's in a higher risk group, you may want to be considering transplant earlier on rather than waiting. It doesn't tell you exactly that that's the thing to do, but it does give you a perspective about when to think about transplant. And these now have been built into calculators that are easily used online. This is something that we often do in clinic. It's really a simple thing to pull up in the clinic and just put all the information in, and it tells you if somebody have low or intermediate or high risk or very high risk of progression. So this is a more refined tool that we use to prognosticate. But again, this is part of why having as much information at the time of diagnosis or when the disease changes is important. So the bone marrow, the genetics, the karyotype, all of that stuff goes into this. Okay, so let me finish with 2 last things. Here's my thoughts and what I would say for patients, key questions that you should really discuss with your physicians. Number 1, it's always a good idea to ask for an explanation about your test results. I think it's our job to educate and tell you why we're running tests, what the tests mean, what their implications are. That is something that I definitely believe. I think you should ask, what is my diagnosis? And is there any ambiguity with regards to my diagnosis? Going back to the boxes in the first slide, right? It may not fit conveniently into one of these boxes, but you have to know that, right? Because that can change management or prognosis. Second, can you tell me if I have bone marrow fibrosis and how much and what does that mean, right? It's different in different contexts, but you should interrogate about that particular issue. Can you review my cytogenetics with me and explain what it means, right? The karyotype. Have they done it? What does it mean? What are the findings? And finally, can you review my mutation results with me and explain what they mean? So I think these are some of the key things that I think it's important to ask your doctor about. Okay, last slide, closing thoughts. On a high level, what are we trying to do? I think our goal is really to make and give patients the opportunity to live the longest life possible and the best quality of life possible, right? And a lot of what you're going to hear today is really centered around those aims. But part of that is making sure that you're empowered to know what it is you're dealing with. And hopefully that's what some of we've achieved today. The last thing is that things are on the verge of changing immensely in MPN. I mean, it's incredible. We have a number of different representatives from different companies. To have so many different companies involved in such a rare set of diseases is actually pretty telling that there's a lot to do here, and there's about to be a major change. So that is the optimistic, forward-looking statement. Okay, thank you so much for your attention.